The WHO defines hypertension as a systolic blood pressure of more than 140 millimeters Hg and/or a diastolic blood pressure of more than 90 millimeters Hg. Hypertension is of various types, and it is often accompanied by other comorbidities. Hence, we cannot treat it with a single type of drug. Different drug combinations are used to treat specific patient situations. Well, first see all the antihypertensive drug classes in detail, and then we'll study about how to use them correctly.
Blood pressure regulation is not a single, isolated action. It's a delicate balance. It exists within a highly interconnected system. To manage it, we must intervene across four main areas: fluid volume, hormonal resistance, neural tone, and vascular muscle. We're now going to explore the entire structural framework of pharmacological intervention. Let's look at this systemic atlas. Notice the central nervous system at the top. Trace the pathways down to the heart. The heart controls your cardiac output. That's the total amount of blood being pumped. Further down, we see the kidneys and the adrenal glands. These are absolutely essential for fluid balance. Finally, observe the peripheral vasculature spreading throughout the body. These are all critical targets. Each one plays a very unique role in managing blood pressure. Now let's look at the fundamental math of the human body. Blood pressure is defined by a specific equation. Blood pressure equals cardiac output multiplied by total peripheral resistance. Cardiac output is how much blood your heart pumps. Total peripheral resistance is the resistance your blood vessels offer to that flow. It's that simple. Every single medication we discuss today targets one or both sides of this equation. We begin our continuous path with Class 1, the diuretics. These are our first-line treatments. Initially, diuretics work by dropping your plasma and extracellular fluid volume. This is essentially the liquid portion of your blood. They reduce this volume by 5 to 15%. This directly reduces cardiac output. Over the long term, your cardiac output actually restores itself. However, your blood pressure remains low. Why? Because the total peripheral resistance drops. The vascular smooth muscle develops a persistent sodium deficit. This makes it completely unresponsive to constrictor stimuli. Let's examine the specific medications in this class. First, we have the thiazides. This group includes hydrochlorothiazide, chlorothalidone, and indapamide. Chlorothalidone is often favored. It lasts much longer in the body. Thiazides are reinstated as the absolute first-choice treatment for uncomplicated hypertension. They're administered in very low doses. We use 12.5 to 25 milligrams per day. We do this to maintain efficacy while minimizing side effects. Specifically, we want to avoid hypokalemia. That's a dangerous drop in blood potassium levels. We also want to avoid glucose intolerance. The diuretic spectrum continues beyond thiazides. We also have high-ceiling or loop diuretics. Furosemide is the primary example here. Furosemide is a much stronger diuretic. However, it's actually a weaker antihypertensive. Its brief duration allows the body to reabsorb sodium, therefore it's reserved strictly for complicated hypertension. This includes chronic renal failure or refractory congestive heart failure. That means heart failure that doesn't respond to standard treatments. Then we have aldosterone antagonists. These include spironolactone and eplerenone. They lower blood pressure slightly, but they're crucially used alongside thiazides. They beautifully prevent that dangerous potassium loss. We flow seamlessly from fluid volume directly to the hormone cascade. This brings us to Class 2, the renin-angiotensin system inhibitors, or RAAS inhibitors. This system is a major regulator of blood pressure. The latest class here is the direct renin inhibitors. Aliskiren represents this group. Aliskiren works by blocking the catalytic or chemical triggering activity of renin right at the very start. This completely stops the production of angiotensin I and angiotensin II. Next in this hormone cascade, we have the AC inhibitors. These are first-choice drugs for essential hypertension. The list includes captopril, enalapril, lisinopril and perindopril, as well as ramipril, falcinepril, quinapril, and trendolapril. They offer remarkable clinical benefits. They improve renal blood flow, they retard diabetic nephropathy, which is kidney damage caused by diabetes. They even regress left ventricular hypertrophy. That means they reduce unhealthy thickening of the heart wall. But there's a distinct warning here. They can cause a persistent dry cough. This cough is caused by increased kinin levels, and it often requires stopping the medication entirely. If a patient develops that dry cough, we use angiotensin receptor blockers. We call these ARBs. These drugs directly and physically shield the AT1 receptor on the blood vessel wall. The medications in this group are losartan, candesartan, and valsartan, along with telmisartan, irbesartan, and olmesartan. They offer the exact same metabolic and prognostic advantages as ACE inhibitors. The crucial difference is they do not increase kinin levels. Therefore, there's absolutely no cough side effect. Our journey glides directly to the vascular smooth muscle. This is class 3, the calcium channel blockers, or CCBs. Think of them as the vascular keyhole. Their core mechanism is simple but incredibly powerful. They lower blood pressure by decreasing peripheral resistance. They achieve this via direct vasodilation. The calcium channels are blocked. Because of this, the vessels relax. Importantly, they operate entirely without compromising cardiac output. This makes them exceptionally safe for patients with asthma or peripheral vascular disease.
We must understand the intra-class matrix of these calcium channel blockers. There's a very strict usage rule we must follow here. We only use long-acting preparations for chronic management. We strictly avoid short-acting forms. Why? Because short-acting forms cause rapid, extreme drops in blood pressure. This severe fluctuation carries significant cardiac risks.
Let's clearly list the specific calcium channel blockers. The largest group is the dihydropyridines. This includes amlodipine, nifedipine, felodipine, and cilnidipine, as well as lacidipine, lurkinidipine, benidipine, and nicodipine. Next, we have the phenylalkylamine group. This is represented by verapamil. Finally, we have the benzothiazine group. This is represented by diltiazem. We now connect vascular muscle directly to neural tone. Welcome to Class 4, the sympathetic inhibitors. First, we look at the beta-adrenergic blockers. These include propranolol, metoprolol, and atenolol. Historically, these are first-line treatments. However, their status has been downgraded. They are now reserved for compelling indications only. We use them primarily for patients who are post-myocardial infarction. That means they've survived a heart attack. They're much less effective for primary stroke prevention when used in monotherapy, that is, as a single drug treatment. Within the sympathetic inhibitors, we also have combined agents. These are the alpha and beta adrenergic blockers. They act on both receptor types simultaneously. Labetalol is our first example. It acts much faster than pure beta blockers. Because of this safety and speed, it's preferred for treating preeclampsia, that's a dangerous high blood pressure condition in pregnancy. Our second example is carvedilol. Carvedilol is very commonly used for managing chronic heart failure alongside hypertension. The crucial point here is understanding exactly where these neural drugs act. We have peripheral alpha-adrenergic blockers. These are prazosin, terazosin, doxazin, and phentylamine. They block alpha-1 receptors. This dilates both resistance and capacitance vessels, meaning both the arteries and the veins. But we must issue a strict warning. They cause a severe first-dose effect. This leads to postural hypotension. That's a sudden drop in blood pressure when standing up, causing fainting. Because they cause fluid retention that can lead to heart failure, there aren't first-line drugs. We also have central sympatholytics. These operate directly in the brainstem. Clonidine is an alpha-2 agonist. It effectively decreases sympathetic outflow. However, it carries an alarming risk. If a dose is missed, it causes severe withdrawal hypertension. Then we have methyldopa. Methyldopa acts centrally in the brain. It does this by breaking down into a compound called alpha-methylnoradrenaline. Today, it's rarely used. Its primary remaining use is in pregnancy. This is due to a very long and established safety record. We transition now from neural tone to direct arteriolar relaxation. This is class 5, the vasodilators. Think of them as the emergency relief valve. Hydralazine is an arteriolar dilator. It works well, but it causes fluid retention and reflex tachycardia. That's an abnormally fast, reactive heart rate. Because of this, it must always be combined with a diuretic and a beta blocker. Minoxidil is another arteriolar dilator. It's an incredibly powerful vasodilator. Interestingly, its side effect of severe hair growth, or hirsutism, serendipitously led to its widespread topical use for baldness.
Within the vasodilators, one drug stands alone for emergencies, sodium nitroprusside. This is both an arteriolar and a venodilator. This means it relaxes both arteries and veins. It's a highly potent, rapidly acting intravenous infusion. We use it strictly for hypertensive emergencies. It works by generating nitric oxide both enzymatically and non-enzymatically. This nitric oxide rushes into the tissue. It causes an immediate, profound relaxation of the blood vessels.
Class 6, the adrenergic neuron blockers. These are now considered completely obsolete. Historically, they targeted the synaptic cleft, that is the tiny space between nerve cells. They interfered with the neurotransmitter vesicles inside the presynaptic neuron. Today, they're largely relegated to the history books, or they're used purely as pharmacological tools in research. We'll list them here simply for completeness. Reserpine is the first. Its mechanism is to deplete catecholamines. Those are stress hormones like dopamine and adrenaline. It does this by inhibiting their storage. The reason it's obsolete is its severe side effect. It causes significant, debilitating mental depression. The second is guanifidine. Guanifidine inhibits the release of noradrenaline from nerve endings. It's completely out of clinical use today. The severe side effects vastly outweigh any blood pressure benefit.
We have traced the entire architecture. This unified matrix brings it all together. We started with fluid volume and diuretics. We moved to the hormone cascade with RAAS inhibitors. We opened the vascular keyhole with calcium channel blockers. We mapped the neural tone with sympathetic inhibitors. We opened the emergency relief valves with vasodilators. And we finally examined synaptic storage with the obsolete adrenergic neurone blockers.
We'll look at the strategy for drug selection first. From there, we'll smoothly transition into more complex scenarios and even crisis triage. So let's take that very first step together. Here we are looking at stepped care and selection. The core of this entire protocol is what we call the stepped care approach. It's actually quite simple in concept. You start therapy with just a single drug. Then you observe the patient carefully. If needed, you progressively add more medications. We call this step 1 or monotherapy. Now, choosing this very first drug depends heavily on something called the patient's renin status. Renin is just an enzyme. It's produced by the kidneys, and it helps control blood pressure. Think of it like an engine. Younger, non-Black patients typically act as a high renin engine. So for them, the best tools are ACE inhibitors or ARBs. On the other hand, older patients or Black patients of any age usually have a lower baseline of renin. For this group, calcium channel blockers or thiazide diuretics just work much better. And that's a quick note, beta blockers aren't generally used as a first-line therapy here unless there's a specific condition that truly requires them. So what happens if that single drug just isn't enough? Well, we simply move to step 2. This is our dual combination phase. Here, we usually combine an ACE inhibitor, or an ARB, with either a calcium channel blocker or a thiazide diuretic. If the blood pressure is still too high, we glide right into step 3. This is a triple combination. You put an ACE inhibitor or ARB, a calcium channel blocker, and a thiazide diuretic all together. But sometimes a patient still won't reach their target blood pressure. We call this resistant hypertension. And that brings us to step 4. At this stage, we have to introduce a fourth drug. If their potassium levels happen to be low, we add an aldosterone antagonist. If not, alternative options include higher doses of a thiazide, a beta blocker, or an alpha-1 blocker. Let's move smoothly into combinations to avoid. As we build out these treatments, it is absolutely crucial to know that certain drug combinations must be strictly avoided. They can be really dangerous. First, never combine ACE inhibitors with ARBs. They target the exact same physiological system, so you get zero added benefit, but you multiply the risks. Second, do not combine verapamil or deltiazem with beta blockers. Doing this causes marked bradycardia. That basically means a dangerously slow heart rate, or it can cause a block in the heart's electrical system. Third, avoid mixing beta blockers with diuretics in uncomplicated hypertension. Why? Because it significantly increases the risk of new-onset diabetes. Fourth, don't mix clonidine with alpha or beta blockers. They actually antagonize its central action. Fifth, never combine hydralazine with DHPs or prazosin. Their hemodynamic patterns are just way too redundant. And finally, do not combine methyldopa and clonidine. They belong to the exact same class of drugs. They suppress the nervous system in the exact same way, which is something we definitely want to avoid. Next, we'll gently shift into pregnancy and crisis management. Managing high blood pressure during pregnancy requires an incredibly delicate balance. We have to protect the mother, but we also have to protect the developing baby. The target blood pressure here is strictly less than 150/80 to 100 millimeters of mercury. This specific range keeps the mother safe from cardiovascular complications. But we have to be so careful not to reduce that pressure too drastically or too quickly. If the blood pressure drops suddenly, it impairs the blood flow to the placenta, and that directly harms the fetus. When we do need to treat hypertension in pregnancy, labetalol is our most widely used and effective oral option. Methyldopa is also highly preferred. It has a very long, proven track record of safety. Nifedipine, in its sustained-release form, is effective too. However, it must be stopped before labor begins because it can actually weaken uterine contractions. For high-risk women, we often utilize low-dose aspirin starting around the 12th week. Now, please remember, certain drugs are strictly forbidden here. ACE inhibitors and ARBs cause severe fetal damage and growth issues. Diuretics are out because they reduce blood volume, which hurts placental blood flow. Non-selective beta blockers are linked to dangerously low birth weights and abnormally slow heart rates in newborns, and sodium nitroprusside is specifically forbidden if the patient has eclampsia. Let's continue our pathway and talk about what happens when blood pressure escalates into a true crisis. A hypertensive emergency is defined by two very distinct factors. First, the blood pressure exceeds 220/120. Second, and this is the critical part, this extreme pressure comes with active target organ damage. This means dangerous physical damage is happening right at that moment, like a stroke or acute heart failure. If the pressure is that high but there's no active organ damage, we classify it as a hypertensive urgency instead, and that is treated much more gradually. For a true emergency, our treatment has to follow something called the velocity rule. The goal is never ever to drop the pressure down to normal immediately. In phase 1, the objective is to lower the mean blood pressure by no more than 25%. This is a highly controlled reduction. It should happen slowly, over a period of minutes to maybe 2 hours. Drastic drops beyond 25% must be avoided at all costs. If the pressure drops too fast, it causes catastrophic organ ischemia. This means the vital organs will suddenly just stop getting enough blood and oxygen, and that can be fatal. Managing these emergencies requires immediate intravenous therapy, and the drug choice is tailored directly to the specific crisis at hand. For example, nicardipine is heavily utilized for strokes or acute renal failure. Sodium nitroprusside is incredibly effective for an aortic dissection, though you do have to monitor closely for cyanide toxicity. Labetalol is exceptionally safe for patients with altered mental function or hyperadrenergic states. That just means conditions where adrenaline is dangerously high. Glycerol trinitrate is ideal for a heart attack or acute heart failure. Esmolol is an ultra-short-acting beta blocker that quickly reduces the heart's workload. And furosemide helps manage volume overload. Also, it is absolutely vital to know that sublingual immediate-release nifedipine capsules have been completely abandoned. They pose severe safety risks. They should never be used. We are now looking at therapeutic aims and risk factors. Let's take a step back and look at the overarching goal here. The primary objective of all antihypertensive therapy is preventing morbidity and mortality. Very simply put, our goal is to prevent illness and save lives. But this has to be achieved with the absolute minimum inconvenience to the patient. We want to avoid severe side effects and lifestyle disruptions whenever possible. It's also important to note that both the top systolic number and the bottom diastolic number are critical. They are independent predictors of harm. So, comprehensive control of both numbers is absolutely essential. You might be wondering, how exactly does this high pressure cause harm? Uncontrolled blood pressure systematically degrades the body. We call this target organ damage. In the brain, it leads to strokes and severe confusion, known as hypertensive encephalopathy. In the heart, that persistent high pressure literally forces the heart muscle to become abnormally thick. This is called left ventricular hypertrophy. Over time, it leads to congestive heart failure and angina. In the kidneys, the pressure physically destroys the tiny filtering units, which causes progressive renal failure. And throughout the entire vascular system, it causes peripheral vascular disease, retinal damage in the eyes, and even life-threatening tearing of the aorta. To protect these precious organs, we meticulously evaluate a patient's cardiovascular risk profile. Demographics matter quite a bit here. Men over 55 and women over 65 face inherently higher risks. Lifestyle plays a massive role too. Smoking, obesity, and a sedentary routine all significantly elevate the danger. Metabolic conditions like diabetes and dyslipidemia multiply those risks even further. We also look closely at genetics. A family history of premature cardiovascular disease is a big red flag. Finally, pre-existing damage like chronic kidney disease confirms a heightened vulnerability. When these risk factors start piling up, the patient's overall danger level rises, and that demands a much lower, much stricter target blood pressure. Let's smoothly transition to our final area, specific clinical indications. Sometimes those standard stepped care rules we talked about earlier have to change. We call these compelling indications. This is where our protocol actually flexes to protect a patient's specific vulnerabilities. For instance, if a patient has heart failure, diuretics and beta blockers suddenly become the core tools. For patients dealing with diabetes or chronic kidney disease, ACE inhibitors or ARBs are an absolute mandate. Why? Because they directly slow down diabetic nephropathy. This literally protects their failing kidney filters from further damage. If a patient is at high risk for coronary artery disease, calcium channel blockers are highly effective. And for long-term stroke prevention, combining diuretics and ACE inhibitors has shown tremendous success. As we wrap up this continuous journey, take a moment to consider something. A blood pressure reading is, at the end of the day, just a number, but the patient sitting in front of you is a highly complex, fragile system. So when does strictly chasing a specific number begin to compromise the person? When does aggressive treatment suddenly threaten delicate thresholds, like placental blood flow for an expectant mother, or ischemic risk during a sudden emergency? The true mastery of this clinical protocol isn't just memorizing the steps. It lies in knowing exactly when to push forward and exactly when to hold back.